My name is David Ahern. I'm a senior advisor to the Connect to Health Task Force and a behavioral scientist and informatics researcher at Brigham and Women's Hospital and on the faculty of Harvard Medical School. I'm very excited today to share with you the agenda we have with an outstanding roster of speakers from a variety of disciplines and geographic reach from both government and private sectors. We've engaged over 30 expert panelists and speakers who will address the topic of broadband connectivity as a social determinant of health from a variety of perspectives. We've structured the symposium to include a series of panel discussions. The first begins with a foundational session on the topic in terms of what we know today and current policy views. The second session is a panel discussion on how broadband connectivity is enhancing health and transforming health and human services, including during the pandemic. The third panel will discuss how it can be fully recognized as a social determinant of health. The fourth will elucidate the implications for government policies, clinical care, and health equity. And the fifth and final session will be focused on research and data. For this symposium, we've also incorporated a fireside chat with Dr. Don Berwick, former administrator of the Centers for Medicare and Medicaid Services, to take a top-level view of the value of broadband connectivity in health and healthcare and its potential to address health inequities. I now want to introduce our first panel segment, which is foundational, as I mentioned. It'll consist of a series of mini presentations and key research addressing the relationship between broadband and health, the emerging evidence that connectivity correlates with health, and policy views on whether broadband connectivity is and should be recognized as a social determinant of health. So with that, I will turn over the microphone to my colleague, Dr. Ariel Mancuso from the Connect to Health Task Force. Ariel?
Thank you, Dr. Ahern, and good morning, everyone. My name is Ariel Mancuso, and I am the Director of Research and Data Analytics at the Connect to Health Task Force, where I lead our research and analytical work that examines the intersection of broadband connectivity, advanced technologies, and health. I completed both my master's and PhD degrees in public health from Johns Hopkins Bloomberg School of Public Health. I wanted to start this morning by sharing some of our thinking at the Connect to Health Task Force about the relationships between broadband connectivity and health, and how we applied the principle of broadband connectivity as a social determinant of health to an analytical framework that identifies need at the intersection of broadband connectivity and health. First, I'm going to outline a conceptual framework that we have been working to develop for three types of relationships between broadband connectivity and health. Later in this panel, my colleague will dig into some of our empirical work that lay the foundation for our thinking on these relationships and resulted in our recognition of broadband connectivity as a social determinant of health. This framework can be used to better understand the types of relationships that exist between broadband connectivity and health that have different analytical, policy, and practice implications. The first type of relationship is probably the one that is most familiar, and this is where broadband connectivity is a tool or resource that is leveraged in the implementation of a broadband-enabled health solution. An example of this type of relationship is when a specific health intervention is delivered using a technology that relies on a broadband connection, such as a glucose monitor tied to a smartphone application that provides alerts or reminders to users. But broadband connectivity is more than just a tool or resource. The second relationship is one in which broadband connectivity acts as a social determinant of health. Social determinants of health are non-medical, non-clinical factors in the environment in which people live that have been shown to have an independent influence on health. While the mechanisms through which broadband connectivity influences health in this way have not yet been established, prior work by the Connect to Health Task Force identified significant differences in important health outcomes between areas that are connected compared to areas that are digitally isolated, even after taking into consideration differences in other factors like income, education, and age. This novel finding suggests an important independent relationship between broadband connectivity and health beyond instances where broadband connectivity is being leveraged for broadband-enabled health solutions. Finally, it is increasingly recognized and brought to light by our experience during the coronavirus pandemic that broadband connectivity is critical to almost all activities of our daily lives, such as work, education, and play. In this way, broadband connectivity may have an even more significant role in health by mediating the relationships that exist between the established social determinants and health. For example, income is a key factor in economic stability, which itself has been shown to influence health, with households that have higher incomes also reporting better health. In today's context, the ability to apply for a job or telework are often enabled through a broadband connection. Thus, broadband is also acting as the gateway through which these established social determinants can influence health. Today, our focus is on these latter two types of relationships, in which broadband connectivity acts as a social determinant of health, if not a super determinant. Next slide, please. Next, I want to turn to how we have applied the principle of broadband as a social determinant of health to an analytical framework that identifies need at the intersection of broadband connectivity and health. We developed this framework to generate actionable insight about who is most at risk or being left behind in meeting broadband health goals. This framework was developed based on prior analytical work by the Connect to Health Task Force that showed that counties that needed broadband connectivity for health the most tended to have it the least. Identification of these counties also demonstrated the existence of areas that faced dual challenges of both low broadband connectivity and poor health. This finding is particularly concerning given the important role of broadband connectivity in health, with the potential to further exacerbate existing digital and health inequities. We have coined this need at the intersection of broadband connectivity and health as the broadband health gap. Here you can see the analytical framework with broadband connectivity on the vertical axis and health need on the horizontal axis. Counties that have lower broadband connectivity are considered more digitally isolated, while counties that have higher broadband connectivity are considered more connected. On the other hand, counties that have higher health need are considered priorities in addressing the current health challenge. By intersecting broadband connectivity and health need, we create 4 categories of counties. Those counties that have lower broadband connectivity and higher health need, shown in dark blue, are counties that are double burdened. These are areas where low broadband connectivity and poor health coincide and may lack the broadband resources or access to the broadband-enabled solutions they need to overcome their health challenges, potentially creating a broadband health spiral. In this spiral, the coexistence of low connectivity and poor health may further limit the ability to access needed connectivity and health resources and exacerbate existing digital and health inequities. On the other hand, areas where broadband resources are already in place but are still experiencing higher health need may be able to leverage these broadband resources or solutions to address their health challenges in the more immediate term. Thus, this framework supports data-driven decision-making by identifying both gaps and opportunities at the intersection of broadband connectivity and health need. This may be used by policymakers or other stakeholders to target and prioritize efforts to leverage broadband connectivity for health and ensure that communities are not being left behind. Next slide, please. This county categorization has been central to much of the analytical work of the task force, and I want to end with a few examples of how we have incorporated this framework into our work. Here's a preview of a map from our soon-to-be-released map book showing the intersection of broadband connectivity and opioid mortality. Counties are categorized into these 4 groups, with double burden counties that are experiencing both lower connectivity and higher health need in dark blue, and opportunity counties with higher connectivity and higher health need in orange. Next slide, please. Next, I want to preview our expanded Mapping Broadband Health in America platform that incorporates data on drug abuse and opioid mortality and enables users to visualize and analyze the intersection of broadband connectivity and health. Here I am showing the intersection of internet adoption and opioid mortality, with counties that have below average internet adoption and above average opioid mortality visualized in dark purple. This platform also enables users to customize the visualization and analytics to better understand the intersection of broadband connectivity and health need that is most relevant to their interests and needs. I'll stop there for now and turn it back over to Dr. Ahern, but I look forward to the conversation today. Thank you so much for the opportunity to share.
Thank you so much, Ariel. Really appreciate that. I'm now going to turn over the microphone to Cotter Blakey. Cotter?
Great, thank you. And thank you for having me join you today to discuss Healthy People 2030 and our approach through Healthy People to address the social determinants of health. And so I am the Deputy Director of the Office of Disease Prevention and Health Promotion at the Department of Health and Human Services. So we oversee a lot of basic prevention policy efforts that the social determinants of health have just grown to play a much bigger part in. So today I thought I'd share just a few thoughts about Healthy People's history and evolution that's led us to where we are today. And that is placing social determinants of health at the core of all we do, not only within the Healthy People Initiative, but just about every programmatic activity we have in ODPHP, as we call ourselves. You know, whether it's the dietary guidelines for Americans or health promotion, communication efforts around health literacy. So next slide, please. So Healthy People for the past 40 years has provided science-based, data-driven national objectives that have 10-year targets aimed at improving the health and well-being of the nation. So Healthy People is grounded in the principle that establishing objectives and providing benchmarks to track and monitor progress over time can motivate, guide, and focus action. And it underpins a variety of HHS and administration priorities and strategic initiatives. It provides a framework for prevention and wellness programs for a diverse array of both federal and non-federal users. And for example, beyond the federal government, Healthy People is used by state and local health officials, community health advocates, researchers, academia, and even businesses, all of whom seek to improve the health of their own constituent populations, whoever that happens to be, and particularly and more by addressing the social determinants of health and trying to achieve health equity. So HHS launched the 5th iteration of the initiative, Healthy People 2030, in August of 2020. In the midst of the pandemic, we were delayed. We had thought we were launching March 30th of 2020, big in-person event with White House representation, HHS, high-level representation. And of course, we all went home March 15th. So we rescheduled for a few weeks later, thinking this was going to be a quick fix to get out of the pandemic. And we ended up not launching till August 2020. So in the recognizing that Healthy People was developed over a series of several years, 4 years before its actual launch, we've had to pivot a bit in our approach to things in Healthy People. So it's been an interesting time. So next slide, please. So this slide depicts the evolution of Healthy People across the many decades that we've existed. And it's really evolved in the way we understand our deepening dependence on the social determinants of health. We've moved further and further upstream toward addressing disparities and equity. And at the same time, we've introduced and expanded our concept of the social determinants of health. So this slide shows the evolution of the overarching goals of Healthy People across the decades. So you can see here that the second generation of the initiative, and that was Healthy People 2000, that was launched in 1990, introduced the concept of reducing disparities. And then moving to the next decade, which is Healthy People 2010, we raised that bar to eliminate disparities. Then moving on to Healthy People 2020, we not only called for the elimination of health disparities, but we also sought to achieve health equity. And we added the overarching goal for the social determinants of health. So the goals in green there. And then now today with Healthy People 2030, we've gone further by adding a goal of attaining health literacy to that eliminating disparities overarching goal. And we've broadened the scope of the social determinants of health overarching goal to encompass economic environments as well as the social and physical. So next slide, please. So I think we all know that efforts required to eliminate health disparities and achieve health equity extend well beyond promoting healthy choices. And in order to improve the conditions and the environment where people are born, live, learn, work, play, worship, and age, public health organizations and their partners, not only in the health sector, but in sectors not traditionally associated with health, must take action. So the social determinants of health framework that's conceptualized in this graphic identifies 5 key domains that influence health. We have economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and the social and community context. So each of these 5 domains reflects a number of critical underlying factors that impact the social determinants of health. So, and I'll add that, I really think that Healthy People 2030 can provide the initial frame of reference we need to move toward recovery from COVID-19 and provide a foundation that we can look to in order to emerge a more equitable and a resilient nation than we knew before the pandemic. So next slide, please. So among the 29 objectives that we've identified as supporting the Healthy People social determinative health domain of neighborhood and built environment is an objective to increase the proportion of adults with broadband internet. This is something that I think the pandemic has shown is vitally important. And in preparing for this presentation, we had some prep discussions. And it's interesting that it was a struggle to get this objective into Healthy People before the pandemic. When you have skeptics who thought, we have internet access, why do we need broadband? So the pandemic has shown that while most Americans in the United States use the internet, they don't have broadband service at home. And there are disparities in home broadband service by race, ethnicity, age, geographic location, education, income, you name it. So, and more hospitals and health systems are using internet-based communication and healthcare tools. So strategies to increase broadband internet access are important to improving health. And elevating the critical importance of this objective right now is all of the factors that were borne out by the pandemic. We have additional objectives in Healthy People that aim to increase access and use of electronic health records, telemedicine, access to quality health information. And without high-speed internet, that can be frustrating for folks. So again, this underscores the importance of this objective. And so that is where we are with Healthy People. I just wanted to give you a sense of the evolution. We started with SDOH in the mid-2000s and felt that we had achieved a huge milestone by actually incorporating the social determinants of health into the Healthy People Initiative. And now we're absolutely delighted that that has spread throughout sectors, not only within the health sector. So we're truly excited by that. So that is all I have. And with that, I think I'm done. But thank you so much.
Thank you, Carter. That was wonderful. We really appreciate hearing about the Healthy People 2030 Healthy People program. I now would like to turn over the microphone to Dr. Natalie Benda. Natalie?
Thank you. So as the panelist here, or one of the panelists here that is in an academic center, I don't treat patients myself. I'm a health services researcher, but I work with a lot of people who do treat patients very closely. And I also spend a lot of time in clinical environments trying to understand how we can better support our patients. My work focuses on trying to utilize technology to advance health equity. So I wanted to bring you all some observations of myself and my colleagues about how broadband internet access really does affect health. First, I wanted to cover two foundational concepts. Many of you may be familiar with these, but I want to make sure that we have some common language with which to talk about. The first concept I wanted to talk about is intervention-generated inequity, which is something that's created when we have interventions such as telemedicine that are extremely well-intentioned, but for reasons such as lack of broadband internet access, they benefit already advantaged groups over less advantaged groups. And I think that's important because by not supporting broadband internet access for all in this country, we are really creating intervention-generated inequities. And I've cited a paper here by one of my mentors and some of my other co-authors if you would like to learn more about this concept. Next slide, please. The other concept that I wanted to mention was digital redlining. Many of you may be familiar with the concept of redlining, not providing credit or services to people that live in particular neighborhoods. Digital redlining is something that we've seen in cities such as Cleveland. This is a photo from 2016 that demonstrated that AT&T was deliberately not expanding fiber optic services to neighborhoods in central Cleveland that happen to be lower income neighborhoods. I bring up this concept because it demonstrates that a lot of these inequities are really systemic, so we can't necessarily just leave it to private industry to resolve these issues. Next slide, please. I believe I was invited to speak on this panel because of a perspective that my colleagues and I published in the American Journal of Public Health in 2020, where similar to many other people on this panel, we highlighted how, particularly in the COVID-19 pandemic, broadband internet access serves as a gateway to information and a gateway to services and these social determinants of health that Carter mentioned that we know affect health outcomes. So coming to this panel as one of the people, as I mentioned, in an academic medical center, I really wanted to bring you some voices and experiences from patients about how broadband internet access has affected their health and their lives. One of my colleagues who is a pediatrician and an informaticist was kind enough to lend me some of her data, and she'll be attributed in the slides. I want to make sure I give her full credit. She works in a pediatric obesity clinic in New York City and did interviews with adolescent patients as well as their parents to understand how their care had been from the clinic during the COVID-19 pandemic. I will say that some of these quotes are a little bit challenging to read and to see, but I thought it was really important to bring you the voices of some of our patients. Next slide, please. Before talking specifically about quotes that patients had given about how broadband internet access affects specific social determinants of health, I first wanted to make 2 points. The first one is this is a clinic in New York City. And I wanted to highlight that broadband internet access is not just a rural problem, it is an issue in urban environments. Secondly, I also wanted to point out that broadband internet access is not simply a binary construct. It's not the haves and have-nots. It's really a spectrum of, do people have sufficient broadband internet access to support the needs of their entire household and remaining healthy? Next slide, please. Some of the adolescents that they spoke with talked about how broadband internet access directly affected their healthcare. And as you'll see with this quote in the corner, there was an adolescent that was not able to have sessions with their therapist because they couldn't go in person and they didn't have sufficient broadband internet access. As a result, that therapist unfortunately dropped them as a patient. And this adolescent even said that they understand that issue, but because of that, they were not able to obtain the medications that they needed, which is a really sad thing to see for this young patient. Next slide, please. There were also issues related to neighborhood and built environment. So some people were talking about how in a pediatric obesity clinic, they're encouraging people to exercise, but they don't live in a safe neighborhood where they're able to go outside and exercise. Many of us may have access to and used, at-home workout videos and things like that during the COVID-19 pandemic. But without access to the internet, this is not something that these children were able to take advantage of. Other children talked about issues related to connection, and we know that this has been a huge problem among particularly adolescents who weren't able to see their friends. And if they couldn't see them in person, they possibly weren't even able to connect with them online, which was another problem that we saw. Next slide, please. And then lastly, there were issues related to economic stability. So if you think about someone who is in a single low-income family and they're already paying $95 a month for Wi-Fi, and the Wi-Fi itself isn't good, it's not supporting their entire family that may be at home, paying $10 more per month just would not necessarily always be an option. And that's why it's important us to think about how broadband internet access can holistically support the needs of particular households, not just single individuals. And then in the other end, if we're thinking about things like food access, if people are at home quarantining as this pandemic continues, but they don't necessarily have the ability to order groceries, thankfully, this person that's quoted here had a neighbor that could help them. There may be some really foundational services that people do not have access to. So I wanted to thank you all for allowing me to be a part of this panel today. And I hope that these patient stories can help us drive the discussion forward.
Thank you, Matt. We really appreciate it. And now we're going to, I think we hope to have a special guest. I don't know if Commissioner Carr is available though yet. So I think what we're going to do is proceed with the next set of speakers, and then we'll introduce Commissioner Carr when he is available. So let me turn it now over to Dr. Summers from the Office of the ASPE group and have him introduce the team and their presentation. Thank you.
Great, thanks so much. We're really happy to be here with you today. So I'm joined by MJ Karimi and Annie Lee. They'll be walking you through our data in a moment. And I just want to briefly introduce what our office is and how we're approaching the broad issues related to telehealth. The Office of the Assistant Secretary for Planning and Evaluation, or ASPE, is essentially the in-house think tank for the Secretary of Health and Human Services. So we do a lot of work around policy evaluation, data analysis, strategic planning, and any work really that can provide an evidence-based approach to the policy decisions that HHS is facing. And telehealth is one of those areas that is of significant interest and priority right now for all of the reasons that the previous speakers have laid out. One of the challenges in analyzing data around telehealth is that it is often payer specific. We have a lot of good data, for instance, on Medicare utilization of telehealth, and our office has put out several reports on that. You've heard some of the highlights on some of the Medicaid specific results, and in all cases, we know that telehealth use surged. But one of the challenges with that is you often can miss the cross payer understanding of health equity. How are we doing in private insurance versus Medicare versus Medicaid versus those who don't have coverage? So one of the key points of the project you're about to hear about really tried to take on that issue of understanding across payers at a full population level. What do we know about telehealth use in 2021? I'll also just reference, I thought, a really important point that Natalie made in her comments. We can make things worse from an equity perspective if we don't do this thoughtfully. Having expanded access to telehealth in the pandemic has been critical, but it doesn't mean that we need to, that if we do exactly what we've been doing for the past 2 years, that it necessarily will lead us to equitable outcomes. And so this study is really to unpack how are things working now, and what does that tell us about our approach moving forward to guarantee access, high quality, and equity in our telehealth use. So with that, I'm going to hand the microphone over to Drs. Karimi and Lee, who are going to take you through our results analyzing national survey data on telehealth use in 2021.
Good morning. Thank you for the opportunity to present. I'm joining my colleague, Dr. Annie Lee, to share some information about ASPI's recent publication titled National Survey Trends in Telehealth Use in 2021, Disparities in Utilization of Audio and Video Telehealth Services. As discussed by the panelists before, the use of telehealth increased dramatically during the COVID-19 pandemic, but research still suggests that access to telehealth was not equitable across different population subgroups. In this presentation, we would like to discuss with you the use of telehealth services during COVID-19 pandemic, share information about the analysis of the Household Pulse Survey, or HPS, on national trends in telehealth utilization across all payers, as well as the use of video-enabled versus audio-only telehealth services across different patient populations. We will also share some of the approaches that we propose on the issue brief with respect to the overall telehealth utilization. Next slide, please. During the COVID-19 public health emergency, all health centers that were funded by the Health Resources and Services Administration, or HRSA, expanded telehealth services. HRSA is an agency of the US Department of Health and Human Services tasked to provide equitable health care to people who are geographically isolated or economically or medically vulnerable. In addition, the Centers for Medicare and Medicaid Services, CMS, also enhanced reimbursement in fee-for-service Medicare and waived geographical restrictions so that providers in various settings could expand the services and continue providing care remotely during the COVID-19 pandemic. Moreover, state Medicaid programs also made changes to encourage greater use of telehealth delivery for healthcare services. While telehealth has many benefits, there is still some concern around equitable access to telehealth services, especially for those with low technology literacy and people with disabilities in general. Prior to analyzing the HPS, we conducted a literature review and noticed that some of the salient points related to telehealth services revolve around access, quality of care, and barriers associated with these services. Next slide, please. To date, many published analyses of telehealth during COVID-19 pandemic have been geared toward specific payers, and they also use claims data to understand the utilization of specific telehealth services, either by audio or video. Research has shown that live video services appear to offer advantages over audio-only services in many clinical contexts. Therefore, we use self-reported data from the 2021 Pulse survey to assess national trends in telehealth utilization across all payers, identify what demographic factors were associated with higher or lower rates of telehealth use, and determine how use of video versus audio telehealth was different across the patient population. Next slide, please. The Household Pulse survey is a 20-minute online survey, which was fielded approximately every week and later changed to every 2 weeks, beginning on April 23rd, 2020. The general goal of the survey is to provide timely evidence on the impact of COVID-19 pandemic on US households. In 2021, the Center for Disease Control and Prevention, National Center for Health Statistics, and HRSA's Maternal and Child Health Bureau partnered with the Census Bureau to include several questions for monitoring changes in telehealth use. We specifically used data from April 14 through October 11, 2021, which is the time period in which the Pulse survey included questions on telehealth use among adults and also in households with children. Beginning in July 21st of last year, the survey added new questions on the telehealth services, basically distinguishing between those rendered via video telehealth versus those with audio-only services. Next slide. The survey new question included the following. At any time in the last 4 weeks, did you have an appointment with a doctor, nurse, or other health professionals by video or by phone? Please only include appointments for yourself and not others in your household. At any time in the last 4 weeks, did any children in the household have an appointment with a doctor, nurse, or other health professional by video or by phone? For those who selected yes, did the appointment take place over the phone, without video, or did the appointment use video? Next slide. We look at the data from weekly cohorts from April to October 2021 for the overall rates of telehealth use, and from July to October 2021 for the type of telehealth services used. We also use survey weights to mitigate non-response bias and first conducted descriptive analysis, testing for bivariate association, and use stratification methods to test for differences across population subgroups. We then developed 2 logistic regression models to identify first, predictors of overall telehealth use, and secondly, predictors of video service among all telehealth users. Between April 14 and October 11, 2021, more than 808,000 adults across all 50 states and Washington, D.C. responded to the survey. 267,000 were from households with at least one child under the age of 18. Among the 670,000 adults who answered the telehealth question, almost 23% reported having utilized telehealth services either by phone or video within the previous 4 weeks. Among adults with child in the household, almost 20% reported that a child in the household had used telehealth services in the prior 4 weeks. Next slide. Our analysis has several limitations that are important for us to note here. The survey response rate ranges from 1.3% to 10.3% depending on the week. Despite using weighted data to mitigate non-response bias, the inherent nature of internet-based surveys can produce a bias based on the respondents' internet accessibility and level of comfort and familiarity with technology. There was also a small sample size of people with disabilities and Native Americans in the data set who responded to the survey, which prevented us of closely looking at this population who would be most often disproportionately affected by the digital divide. However, despite this limitation, our study has several strengths. The pulse survey is timely. It's based on self-reported information from telehealth users, provide direct feedback from patients that is not captured in other data sources, such as medical claims. I will now turn the presentation over to Annie, who will provide you with information on the actual results extracted from the analysis. Annie?
Thank you, MJ. I'd like to start by sharing this graph on the trends in telehealth utilization during the survey period analyzed in the study. As you can see in the blue, from April through early July, telehealth use remained consistent at approximately 25%. There was a slight decline thereafter, but telehealth utilization remained consistent thereafter at approximately 21% through the end of the study period. And this pattern of use was similar for telehealth services for children reported by the adults in the household. Next slide. When looking at the demographic characteristics of overall telehealth use, there were moderate disparities observed among the subgroups. On the left, you'll see telehealth use within subgroups broken down by race and ethnicity. And telehealth use was lower within the white individuals and highest among Black individuals at 26.8%. On the right, the bar chart shows the telehealth use by age. And although you can see that telehealth use gradually increased with age. Next slide. So the yellow column in the second column shows the percentages of overall telehealth use, whereas the third and fourth column show the proportion of video to audio telehealth use. When we look specifically at age, you'll notice that although telehealth use was lower in the younger age groups, 18 to 39, proportionally their telehealth visits by video use was much higher compared to audio. And if you take a look at insurance below, you'll also notice that the highest rates of telehealth visits were among those with Medicare and Medicaid, but their video telehealth use proportionally was low. Compared to private insurance beneficiaries whose overall telehealth use was lower, but proportionally higher in terms of video telehealth use. However, one thing to note, as you can see, is that uninsured individuals not only had the lowest overall telehealth use, but also lower video use as well. Next slide. And other disparities observed are shown here when we specifically looked at the modalities, video to audio telehealth use. Video telehealth rates were lowest among Latinos, Asians, and Black individuals compared to their white counterparts who were at 61.9%. And this is noted in the blue. Blue represents the video telehealth use. Now, when looking at the telehealth use by education subgroups, there's a pattern of video telehealth use that's lowest among those with less than high school degree and increases with higher educational attainment. So in summary, moderate differences in telehealth use, overall telehealth use was observed in race, education, income, and insurance. Furthermore, there were greater disparities among subgroups of video telehealth use compared to audio telehealth use. I'll turn it over to MJ to tell us to speak about the policy implications. Thank you.
Thank you, Annie. Our briefing and findings on the issue brief are consistent with research study that shows disparities in audio-only versus video-enabled telehealth modalities by race, ethnicity, age, education, income, and health insurance coverage. While a phone visit may provide needed access to care in some circumstances, a video appointment may allow a partial physical exam, nonverbal communication, and a stronger patient-provider relationship. Moreover, a video visit may allow the provider to check on a patient's home environment where conditions and family well-being are often intertwined with health. I would also like to add that there are still a lot of research and evidence that we need to generate to better understand in what circumstances does the telehealth visit serve as well as an in-person visit, or when does a video versus audio-only visit suffice for quality of care? We don't have clear answers on a lot of these questions. But what we kind of agree on is that we want to have a set of options available to all patients in order to improve their health and well-being. We also want to create an equity that if a patient needs an in-person visit or a video-enabled visit, they are able to get it and they are not switched by default into something like audio only because that's what they have access to. Also, based on recent research studies, patients with lower incomes may be more likely to use audio-only services because they are at work during the appointments or lack privacy at home. There are a lot of things that a physician can access on a screen. For example, whether a patient is calling with a concern about a rash or an injury and how it's healing with the wound, or if a physician wants to understand a patient's medication, it would be helpful if the patient put the medication on camera or show their insulin syringes to make sure that they are getting it right. So far, we have some good evidence that for behavioral health and substance use concern, the audio-only services can be quite effective. We don't have good evidence for other type of healthcare yet. I believe that although research shows that video visits offer some additional benefits compared with telephone visits, they require more complex setup, video-enabled devices, and broadband internet access, which may present barriers for older adults, lower income households, and those with limited English proficiency. To combat these issues, almost $1 billion from the American Rescue Plan of 2021 was distributed to nearly 1,300 HRSA-funded health centers in all 50 states, the District of Columbia, and the US territories to support a wide range of projects, including equitable access to telehealth services. The disparity is evident in our results, such as that new approaches beyond those strategies implemented during the COVID-19 pandemic will be needed to ensure equitable access to telehealth, particularly video-enabled telehealth services. More specifically, we see a need for new strategies based on culturally competent care to be implemented to ensure increased access to video-enabled devices and overall internet access as the way to ensure equitable access to all telehealth services. The policy discussion around disparities have been a huge factor in assessing and determining telehealth policy needs post-pandemic. And we hope our findings are helpful to policymakers. These results are specifically important for policymakers in understanding the need to increase access to broadband to address video and audio disparities rather than limiting access to audio only or any other modality, which will only result in overall decrease in access to healthcare. The need to add new strategies in addition to those implemented during the pandemic suggests that not only do existing telehealth expansion need to be continued, but also expanded upon to truly address broader and long-standing inequities in healthcare access. Some consideration for the equitable future use of telehealth are need to consider patient-centered outcomes, including patient preferences, content of services and frequency of visit, technology access, and quality of care. In the next slide, I would love to acknowledge the contribution of several of my colleagues at the Office of Health Policy on this issue brief. Thanks again. This concludes ASPI's telehealth presentation today.
Thank you so much, Dr. Summers, Dr. Karimi, Dr. Lee. We are so grateful for ASPI's work in this area, helping us better understand how telehealth is being utilized in this country and the policy implications thereof. So my name is Karen Onije. I am the Acting Deputy General Counsel at the FCC and the Chief of Staff of the Connect to Health FCC Task Force. I'm delighted to be here. And at this point in the program, we have a special guest who will offer some brief remarks. And I am so pleased to introduce Commissioner Brendan Carr. Commissioner Carr is an FCC veteran. He brings nearly 20 years of private and public sector experience in communications and tech policy to his important role at the Commission. He is passionate about 5G and has championed the FCC's work to modernize its infrastructure rules and accelerate the build-out of high-speed networks. Commissioner Carr has played a key role in a groundbreaking telehealth initiative at the FCC, the Connected Care Pilot Program, which supports the delivery of high-quality care to low-income Americans and veterans. We are delighted that Commissioner Carr can join us for today's critical dialogue. Commissioner Carr, welcome.
Well, thank you so much to Karen and the whole Connect to Health team, I mean, I'm reminded of all the work that then Commissioner Clyburn did in helping to sort of stand up and give oxygen and space for this task force to succeed. And when I came in as general counsel of the agency back in 2017, the task force was sort of under the sort of the docket of the general counsel's office, and really enjoyed the chance to work with the team there. And for my part, I really did sort of hit the ground running on a lot of these telehealth issues. And as I've spent time outside of DC, it really brought home the need for us to expand, internet connectivity for these life-changing telehealth applications, and the need to make sure that we are extending these benefits to every single community, every single American. And that's part of why, I worked to stand up this Connected Care pilot program that has as one of its key focus low-income Americans. And I think one of the great benefits of telehealth, as we've been talking about today, is, adherence. You don't have as many missed appointments, because missed appointments come from, transportation difficulties, time off of work, childcare. There's a lot of reasons why people don't end up being able to get in to see their healthcare professional. We can eliminate a lot of that, with telehealth visits. And there's more to it as well. I was up in Utqiagvik, Alaska, which is the northernmost community in America. It sits all the way at the top of Alaska, right on the Arctic Ocean. And I was in the airport there. We either just landed or we were getting ready to leave. I can't remember. And I was just talking to some of the people that were there, and I was telling one woman who lived up there, why we were there, and we were visiting some of the healthcare facilities. And she said to me, you have no idea what it means for us to get to stay in our local community and use telehealth to have access to care somewhere else. Because when we have to leave our family, we have to leave our community, it's a real stressful situation. It's sort of a shock to the system. They have an entire care community up there. And so when we can keep people with their families in their community and still get high quality care to them, it's a real game changer. And I think one of the things that I was struck by years ago at some of the work that the Connect to Health Task Force was doing was the mapping efforts. And when you look at, where do we have low income communities, where do we have poor health outcomes, and where do we have a lack of access to affordable broadband, those three things tend to cluster together. And inserting an affordable high-speed connection there isn't going to be the panacea that solves all the problems that a community like that may be having, but it can really go a significant way towards doing that. And so with the FCC, we got to make sure that we get affordable internet connections to every community, and we're doing that. We got a lot of programs on that, including setting up new low-income programs that can help. We've got a lot of these healthcare programs we're doing as well. And frankly, a lot of this now comes down to Congress. We need to make permanent a lot of the regulatory relief that HHS and others stepped up to the plate at the beginning of the COVID-19 pandemic that enabled a real spike in telehealth usage. And a lot of those regulatory waivers are set to expire once the pandemic declaration ends. And so we need to make sure that we make permanent those changes that have worked, because we really cannot afford to go back to the status quo before COVID in terms of some of the restrictions that were in place on access to telehealth. So thanks again for the team for letting me offer a couple of words of support, really getting a lot out of these events. And thanks to the task force for everything that you all have been doing. Thanks.
Thank you, Commissioner Carr, for joining us today and for those comments. Very, very timely and important points that you've made. I now want to turn it back to Karen Amije to be our final presenter on this panel. Karen?
Oh, thank you, David, so much. And good morning again, everyone. It is wonderful to be here talking about a topic that is so important to the Commission and frankly to every American. And as part of its overall mission to explore the intersection of broadband, advanced technology, and health, and to advise the Commission, the task force periodically conducts research and data analytic projects. And my colleague, Dr. Mancuso, mentioned this at the top of the hour. We'd like to bookend a little bit with just one example of some of the kinds of findings that we have here around broadband as a social determinant of health. The paper that we want to highlight today is titled Broadband Connectivity as Superdeterminant of Health. And we first did this work back in 2017, but the findings really, as Michelle said, stand the test of time. The task force asked a deceptively simple question. What is the relationship, if any, between the level of connectivity in a community and that community's health? And we wondered whether increasing broadband connectivity in a community correlates to improved health outcomes at the community and population level. Could broadband connectivity be one of the building blocks of health, like the other recognized conditions in which people live, work, learn, and play, the so-called social determinants of health? And I'd like to take a minute just to share some of what we found, what we learned. But let me emphasize two things. First, we believe that analysis at the community level was and is critical. A community level examination can help us better evaluate connectivity as part of the environmental context that influences and sustains health. And that unit of analysis, for example, the county level, is one place where a broadband intervention can be more easily deployed. So that's the first caveat. The second is that our analysis and modeling, what I'm going to share with you in a minute here, what I think the slide that has been brought up is beginning to show, examines correlation, not causation. And that's a really important point for us to make. The work we did was both descriptive and predictive. And what we did was we used diabetes prevalence as a health proxy to look at a couple of things. First, we wanted to look at the correlation between health outcomes and broadband access. We also wanted to look at the correlation between health outcomes and internet adoption. And last, to test those findings, to make sure that what we were seeing really was real, we took a targeted look at both access and adoption in two critical subpopulations that many of the speakers thus far this morning have talked about: rural counties and counties with high levels of health need, in this case, diabetes. And just for clarity, because nomenclature is so important, broadband access in this study was the percent of the population with access to high-speed internet at home at a speed of 25 megabits per second download and 3 megabits per second upload. Internet adoption was the percent of the population who not only had access, but actually subscribed at home. And we divided these metrics into quintiles. So 0 to 20% of the population, 20 to 40% of the population, and so on. So with that background, we used 2015 broadband data from the FCC. We used the CDC diabetes prevalence data. And here are the really surprising, but important results that we found. I'm going to show you 3 bar charts, and I think one of them is up on the screen right now, and we're going to talk through this very quickly. The entire study obviously is on the Commission's website. So this slide is about access. And we found that counties in any quintile of broadband access had, on average, 9.6% lower diabetes prevalence than those counties in the next lower quintile of access. So let me point you here on the slide. We're talking right now about, on the x-axis, we have the percent reduction in diabetes prevalence as broadband access and internet adoption increase. So that's what you're looking at on the x-axis. On the y-axis, there are the variables that we're controlling for. So we're focused here on that first yellow bar showing 9.6% decrease in diabetes prevalence as broadband access increased. And as you can see on the slide, the difference in diabetes prevalence in these communities remained statistically significant, even when we controlled for potentially confounding factors like education or income and age. Same with adoption. I won't spend a lot of time on that. We found that broadband adoption appears to have an even greater correlation to improved health outcomes. We're now looking at that green bar, right? And communities in a given quintile of broadband adoption on average had a 16.5% lower diabetes prevalence compared to communities in the previous quintile. And again, this increase in prevalence remained when we controlled for education, income, and age. Could you go to the next slide, please? Now, this slide is going to look very similar, but what we're looking at here is a snapshot for rural communities. Similar pattern, 2.5% decrease in diabetes prevalence when quintiles of access, of broadband access increased, and an 11.4% decrease between quintiles of adoption. Again, holding constant even when you correct for education and income. Can you do the next slide, please? Great. And then we thought maybe what we need to do is to look at counties with very high health need. And so we looked at counties with the highest levels of diabetes prevalence, the so-called diabetes belt, if you will, where you might expect it to be harder to observe this kind of correlation. And again, increasing quintiles of broadband correlated with decreasing rates of diabetes prevalence. So the next thing that we did is we thought that is very descriptive. Maybe we could create a statistical model to model the impact on health of improving connectivity in poorly connected communities. In other words, could we create a model of connectivity-mediated health improvement among a hypothetical population of people with diabetes? And I don't obviously have the time today to review that model in detail, but what we saw in modeling the data is that for each quintile increase in broadband access and internet adoption, there was a corresponding decrease in diabetes prevalence. And given the high rates of diabetes in this country, even relatively small reductions, we know this to be true, even relatively small reductions in prevalence can change the lives of tens of thousands of people. Last slide, please. So in closing, I think what this research study suggests is that there appears to be a connectivity continuum from access to adoption to utilization that may be influencing health in some way. And this has significant implications, we think, for our policies and interventions. And more importantly for our dialogue today is the finding that the relevance of connectivity to health is not just a question of how often and how starkly broadband correlates to health outcomes, although that's clearly important. But we have both connectivity's potential impact on health plus its status increasingly as a pathway to other determinants of health. Education, access, economic stability, healthcare access and quality. All of those things are increasingly premised on broadband access and the ability to connect to online activities and resources. And for us, that puts the digital divide in stark context. I feel all of the speakers on this panel have been really making a central point here. But what's the good news? So the good news is, while we believe that health is a compelling use case for driving broadband access and internet adoption, so the synergies for our health and communication sectors are clear. And with that, I want to echo my colleagues in saying how much we look forward to the rest of today's dialogue, to the mutual learning ahead. David, I think at this point, we are going to take a very brief break. Is that correct?
I'm sorry, Karen, I was on mute. I think we may have a question. We may have time. We're actually doing very well. It's 11:19 according to my time. So we actually have a few minutes. And I believe there may be a question that we could pose to the panelists.
Thanks, David. This is Samruddhi Thakur with Myriad Corporation. Yes, we have several questions coming in. And one question from Ariel Santos is to Dr. Somers and MJ and Annie, and I believe Dr. Somers will be delighted to address this question. The question is, the presentation just showed that audio options cannot just be eliminated. It has its own merit, not perfect, nor optimal, but better than no access. Dr. Somers?
Yeah, thank you so much for that question. I think that's a really important framing issue for the findings that the team presented. So when you see significant disparities in the use of a service, and you see that there's kind of almost two tracks going on, where we have some groups that are disproportionately using video telehealth and some that are disproportionately using audio, I think there are two policy reactions that we need to have. The first is to make sure that, to the extent that audio only is the only feasible pathway for some of those that care to get delivered, that we protect that access. But the second is that we don't resign ourselves to a two-tiered system where we say we're going to allow certain populations to not have access to the benefits of what we think to be a higher value service, where your clinician can see you. And so, before I took this role, I was working as a primary care doctor in a community health center and seeing patients during the pandemic via telehealth. And it's a big difference when you're on the phone versus when you can actually see your patient, read their face. They can see yours. You can look at medications on screen. You can see their home environment. So these factors really matter. And so I think we have to protect that access, but we can't settle for it. Meaning that we need to continue to make the investments that allow us to eliminate the gaps and make sure that anyone who wants to can get the highest value of care. And that sometimes will be fine to be audio, sometimes that will require video, and sometimes it will need to be in person. So, but we don't want to settle for a two-tier system. I think that's a critical point.
Thanks, Dr. Somers. And I want to take opportunity to pose another question to you or MJ and Annie to address. Is SP looking at tele-intensivist services and how that can help rural hospitals post-pandemic who may have ICUs but not staff-to-staff ICU beds? And this question comes to us from Jeffrey Johnston.
So in our survey data, we are fairly limited in our ability to look at the type of service delivered. In our Medicare claims, we are able to get much more granular. And so we have also published some reports looking at the Medicare fee-for-service claims and the telehealth use patterns, including some by specialty type. I don't believe we've drilled down yet to the point of intensivists versus other specialists, but we, for instance, look at primary care, specialty services, and behavioral health. But it's an important question and a good one that I'll take back to the team. So thank you for that suggestion.
Fantastic. Thank you, Dr. Somers. And I think we might be able to get in one additional question. And Karen, I'm going to pose this to you. This is a question in the form of a comment, again from Jeffrey Johnston. Subscriptions is driven by affordability, and so price for access is important. If there are just one company in rural area and price is not affordable for low-income household, perhaps looking at competition to drive prices down would be an opportunity for further inquiry and policy. And I know this is not a question, it's a comment. And Karen, do you want to go ahead and address it?
I think it is a very salient point. Clearly, affordability is a key part of the puzzle here. And one of the things that we are cognizant of is that there really is a bit of a cycle. So if health is a compelling use case for broadband, extending broadband access and driving adoption, then the more there's utilization of broadband in health, both by providers, consumers, and other stakeholders in the healthcare context, the greater the demand, right? And the greater the demand, the more potential competition and entry. And the more competition and entry, the lower the prices and the greater the demand. And so at the commission, we absolutely recognize that cycle. There are, as Commissioner Carr and Commissioner Starks and Michelle Ellison all noted, there are various programs at the commission focused directly on that affordability question, especially for low-income Americans. I think it needs additional focus, both from a framework standpoint, as well as an intervention standpoint. And clearly those are both underway. And thank you.
Thank you, Karen. And I know we are on time, so back to you, David.
Thank you, Samruti. And I want to thank the panelists. This was a tremendous panel. It's remarkable that we started on time and we've ended on time. And so we now have programmed in a 10-minute break for you from 11:25 to 11:35. We've asked that you come back promptly and be ready at 11:35, where we'll begin our fireside chat with Dr. Don Berwick. So thank you all for participating so far, and we look forward to chatting with you in a few minutes.
Thank you.